Good afternoon, everyone. For those of you who are at the Royal Victoria Hospital, you are welcome to join us. We do have a light lunch for you in D02-1312. Second floor, go towards the D Pavilion. You're welcome to join us in person. Otherwise, you can stay online. This is our first Grand Rounds of the year. We're very happy to have people here in person and those of you out there in the virtual space. Just before we start, I'd like to make a brief land acknowledgement. McGill University is on land which has served as a site of meeting and exchange amongst Indigenous peoples, including the Haudenosaunee and the Anishinaabe nations. We acknowledge and thank the diverse Indigenous peoples whose presence marks this territory on which peoples of the world now gather. Just a reminder to please leave your questions till the end. Please enter them in the chat. And as well, before we get started, I'll ask you to please answer a brief survey that will be sent to you at the end of the presentation. This will let us know that you were here today. So we have a speaker today from the Division of Physical Medicine and Rehabilitation, or also known as physiatry. And the topic today will be on heterotopic ossification from bed to bedside. I'd like to introduce Dr. Chan Gao, our speaker today. He is an assistant professor in the Department of Medicine and an academic physiatrist at McGill University. He completed his MD at Peking University in Beijing in 2003 and his PhD at McGill. As a PhD candidate while at McGill, he acquired extensive knowledge and expertise in skeletal phenotyping of rodents, which required development of quantitative micro-CT imaging and its correlation with histologic analysis. He also did residency training in physical medicine and rehabilitation at Vanderbilt in Nashville from 2015 to 2019, and fellowship in primary care sports medicine and interventional spine at the Icahn School of Medicine in New York. He joined McGill in June 2020, so a fairly recent recruit, and has established a preclinical research program in spinal cord injury-associated heterotopic ossification and neuropathic pain. His research is currently supported by the FRQ-S, AO Spine, and North American Spine Society. Welcome, Dr. Gao. Thanks for being our first speaker this year.
Thank you very much for the comprehensive introduction. And I'm pressured and thrilled to be here to present in the first grand round for this semester. So the topic of my talk today is the heterotopic ossification. It shows from bench to the bedside. I have no disclosure. So HO is a formation of the actual skeletal bone. It is considered as a subsequent of aberrant tissue repair. So 70% of the HO is preceded by a definite injury event that include traumatic event, like an elbow fracture, dislocation, blast injury, and also happens after the orthopedic surgeries. The common ones are hip arthroplasty, burn injuries, neurological conditions like spinal cord injury and the brain injury are the common ones, and the other conditions. COVID infection can trigger the HO formation as well. And then for the rest of the HO, about 25%, you cannot identify a definite traumatic event, and they are considered to result from the microtrauma or repetitive injuries. So examples of this category include the ossification of the posterior longitudinal ligament, OPLL, and the diffuse idiopathic skeletal hyperostosis. So here is the X-ray of the HO, and you can see the bone mass happens around the joint. And the clinical presentation based on the stage of the disease and the location of the HO. In the early stage, they present like inflammation. The patient have pain, tenderness, swelling, redness. For the later stage, when the bone mature, the patient have a limited ROM of the big joint, and they can present the symptoms related to the nerve compression, vessel compression. And so, for example, here, if the patient have the OPLL, and this OPLL, ossification of the posterior longitudinal ligament, that compress on the spinal cord, the patient can present as a cervical myelopathy. The pathogenesis of the HO is very complicated. This is an oversimplified illustration of the soil and the seed theory. So the seed means the osteoprogenitor cells. The soil means the microenvironment that is rich in osteogenic cues. So the inflammation, the microenvironment was contributed by the inflammatory cells, the cytokines, neuropeptides, neurotransmitters, and the vessels, extracellular matrix, etc. A lot of them. And the inflammation reaction is the key here. So the inflammation reaction can trigger the osteogenic cascade inside the cell that cause abnormal conformation. There's a rare form of HO that is congenital. The most common one is the fibrodysplasia ossificans, the progressive FOP. This is caused by a gain of function mutation in the gene that encodes activin A receptor type 1, ACVR1. It's also known as activin receptor like kinase 2, ALK2. So HO can happen secondary to the minor injuries like venipuncture. The HO happens in the muscle, in the ligament, in the aponeurosis. And these patients normally have congenital skeletal malformation. And over the time, they develop the difficulty with the posturing, gait, and the respiration. The management of the HO, currently, the only curative treatment is surgical resection. It is indicated for the persistent symptomatic HO that caused by the mature HO. The problem of the surgical resection is that it has a high recurrence rate. The recurrence is especially high if the surgical resection is performed for the immature growing HO. And also, surgical resection can be complicated by the neurovascular injury as well. The non-surgical treatment is primarily prophylactic, and most of them are non-specific. The specific non-surgical treatment are still in the research phase. I'm going to talk about that today. So because inflammation is a key player for the HO formation, so the anti-inflammatory treatment is widely used for the HO prevention. NSAID is one of them. It's indicated for the hip surgery, elbow injury, spinal cord injury, SCI. And the non-selective and the selective shows the similar efficacy. And the side effect of the NSAID is a concern related to the wound healing process. It may cause a fracture non-union. And the corticosteroids, the prophylactic use of the corticosteroid is indicated for the FOP. And for the patient with FOP within the 24 hours acute inflammation flare. Bisphosphonate has been used for the HO prevention. So this is a meta-analysis compare the medical treatment in preventing the SCI, spinal cord injury associated with the HO. So when compared to the placebo, generally speaking, the medical treatment did not prevent the HO in the spinal cord injury. But if we do the subgroup analysis of the two trials that use NSAIDs, so NSAIDs shows the benefit in preventing SCI associated with the HO. However, when you do the sub-analysis for the bisphosphonate studies, and the bisphosphonate did not show benefit in preventing SCI associated with HO. So the evidence for supporting bisphosphonates in preventing SCI-related HO is not very strong. So radiation therapy is established treatment for the hip HO, and it is so 4 to 8 degree was applied before 24 hours pre-op and up to 7 hours post-op, and it shows better effect for the hip prevention than the elbow. The side effect is fracture non-union, joint stiffness, and the potential oncogenesis. And so far, people don't know why the radiation can prevent the HO formation. And so because inflammation plays a very important role here, so there is a study that studied the immunocomponents of the radiation. So what they do, what they did here is to collect the bleeding, the hematoma from the total hip replacement. The THAH refers to the patient without radiation. THAXH means that the patient had radiation pre-op. And so the radiation leads to increase the frequency of the CD8 positive cytotoxic T cells. And also radiation increased the subgroup of the T regulatory cells. The concentration of VEGF, the potent angiogenic factor, was reduced in the radiation group. So in conclusion, the radiation may change. The radiation changed the immunocyte composition and the cytokine profile. That might be the contributing factor for the prevention of the HO formation. Physical therapy. Physical therapy is normally considered as safe, as like a harmless intervention. But when it comes to the HO, it's not controversy-free. So when I was doing my residency, I was taught early physical therapy with ROM exercise is the first line intervention to prevent HO. However, the early physical therapy is not endorsed by some burn surgeons. So here's a study I want to show is about that show the exercise effect on the burn-related HO. So they use a mice and they make the burn injury on the back of the mice, and also they perform the Achilles tenotomy. And after the surgery, the mice were randomized to 4 exercise groups: passive ROM group, treadmill run, mobilize the group, and immobilize the group. And the immobilization reduced the HO formation. The histology, the histochemical staining with the oil red and immunostaining of perilipin show that there's a significant higher amount of fat formation in the Achilles by the immobilization. And also immobilization can reduce the mechanotransduction signals, and which is shown by the immunostaining of the focal adhesion kinase, as well as the immobilization can reduce the nuclear translocation of a TAS. TAS is an important transcriptional coactivator for the osteochondral differentiation. For the specific treatment, there is a lack of specific treatment nowadays for the patient care. A lot of them are in the research stage. The animal models are instrumental for the novel treatments investigation. So there's a different type of animal models to mimic a different type of HO. The genetic models with the ALK2 mutation to mimic FOP. The traumatic models with the acquired traumatic injury to simulate the traumatic associated HO. At the same thing happens in the neurogenic HO. There's a specific animal model to mimic that. So here I want to present a hallmark study that was published in 2008, and the Q207D mutation in the ALK2 gene that can cause expression of active ALK2, and this ALK2 gene gene expression can be induced by the recombinase, recombinase, which was delivered by the adenovirus vector injection. So after the adenovirus injection, the abnormal active ALK2 was expressed and the HO forms in the injection site. However, when these mice were treated by the LDP, which is a specific inhibitor of the BMP signaling, the HO volume was reduced. When we do the histology analysis, the recombinase in both vehicle and the LDP treatment group was not changed, as shown, and it was successful, as shown by the negative beta-gal staining. However, the BMP signaling was significantly reduced in the LDN treatment group, which is a strong stain in the vehicle treatment group. So this suggests that the BMP signaling is potential therapeutic strategy for the HO treatment. And in this study, they designed another another transgenic animal model that achieve growth expression of the active ALK2 with the induction of a tamoxifen. And if the animal has the growth expression of the active ALK2, they do not form HO. However, when the mice have the control vector adenovirus vector injection as a cuff, and they have abnormal HO formation as shown in the cuff. So this study highlights the importance of the tissue inflammation and the injury to the HO formation. Only expression of abnormal and active ALK2 is insufficient. So this is another transgenic animal model that harbors the mutant gene that is commonly seen in the FOP. And this active ALK2 is expressed by the doxycycline treatment When the mice have the activin A injection into the right cuff, there's abnormal bone formation. If the mice was treated by the rapamycin, the HO volume was decreased significantly. We all know that rapamycin is an inhibitor of the mTOR. mTOR is a mammalian target of rapamycin. mTOR is a catalytic subunit of two different protein complexes, mTOR complex 1 and mTOR complex 2. Raptor is specific for the mTOR complex 1, and the Richter is a specific component of the mTOR complex 2. In order to elucidate the function of the different mTOR complex in the chondrogenesis and osteogenesis, the induced mesenchymal stem cells collected from the FOP was cultured in vitro, and the different component of mTOR complex was knocked down by the siRNA. And when the induced mesenchymal stem cells from the FOP was cultured with the stimulation of activin, there is a strong chondrogenesis. However, the knockdown of mTOR and the knockdown of the Raptor, which is the complex 1, that can reduce the chondrogenesis. Knockdowns the complex 2 that did not change the osteogenesis. So this data suggests that it is the complex mTOR complex 1 that plays a major role in the chondrogenesis in vitro. And after we know that the mTOR is involved for the in vitro chondrogenesis and the in vivo HO formation, the next question is that whether rapamycin interact with the BMP and the TGF signaling. In order to do that, and the Western blot was performed with a specific inhibitor of the BMP signaling and the TGF signaling. And from the Western blot, you can tell, and the RAPA did not inhibit the BMP signaling or TGF signaling, indicating that the rapamycin inhibits the HO formation by a mechanism that is independent from the BMP and the TGF beta. In another study, the RIPA was found to decrease HIF-1 alpha, hypoxia-induced factor 1 alpha. That is an important molecular mechanism for the osteogenesis as well. And mesenchymal stem cells collected from the mice tendon was cultured under the hypoxia condition. And the RIPA was found to decrease the HIF-1 alpha to the same degree as comparable, very comparable to the PX478. PX478 is a specific inhibitor of the HIF-1 alpha. And this HIF-1 alpha inhibitor was tested in the animal model as well. And also here they used the burn-associated HO. And the mice have the burn injury on the back and the Achilles tendon on the ankle. And so the ankle side with the Achilles tendinotomy was shown to be hypoxia in the HIF-1 alpha reporter mice. And after 6 weeks, and you can tell the RAPA treatment and the PX478 treatment reduced abnormal bone formation around the ankle significantly. So histology showed that the PX478 reduced the cartilage formation as well as expression of chondrogenic markers, the SOX9 at 3 weeks. That explains why there's a reduced HO formation. So now we are talking about the retinoid receptor. This is another important molecular mechanism in the bone formation. We know that the retinoid acid receptor agonist can decrease the bone formation by a mechanism that increases the secreted freeze-related protein 4. The palovarotene is activist of the retinoid acid receptor. And so palovarotene was found to reduce the HO formation induced by the cardiotoxin injection in the transgenic mice that express the abnormal active ACVR1, ALK2. And after 3 weeks, and you can tell the cartilage formation in the muscle was reduced by the palovarotene treatment. What's more, when we do the BRDU staining, and the fibroproliferative response was also significantly reduced by the palovarotene treatment. Palovarotene actually has gone through a clinical trial. This trial is called the MOVE trial. This is a single-arm, open-label phase 3 trial. And the participant in this trial over 4 years old, and they take the palovarotene once every day. And the result was compared to a natural history study. And so this paper presents the 18 months interim analysis. So in this paper, there's a totally 97 participants in the MOVE trial were recruited. And there's a 101 individuals in the natural history study was involved. For the natural history study, the patient did not receive any specific treatment except for the insights, except for the standard of care. So the primary endpoint of this study is annualized the new volume of HO. And so the palovarotene led to a 60% reduction in the raw annualized volume of new HO. And they also calculate the model fitted annualized volume with new HO, and the result is consistent, which is a 54% of reduction in the new volume of the annualized volume of the new HO. In this study, all the palovarotene treated patient reported at least one adverse event, and 97% reported over one retinoid-associated adverse event. The most common adverse event is the mucocutaneous event, such as dry skin, lip dryness, alopecia, drug erection, and pruritus, as well as some muscular complaint, such as arthralgia. And the serious adverse events is the premature physical closure in those who have unclosed, who is skeletal immature. And also there's a decrease of vertebrae bone mineral density and also increased the risk for the vertebrae fracture. FDA just recently approved the palovarotene for treatment of FOP, and they are indicated for adults, and also they are indicated for the pediatric FOP. As long as for the girl, they need to be older than 8 years old, and for the guys, for the boys, they need to be older than 10 years old. So now I'm going to talk about the neurogenic HO. That is what I'm interested in my research. Neurogenic HO is a subtype of HO that happens after the central nervous system injuries, including spinal cord injury and the brain injury. So they always affect the large joint, hip joint, the knee, elbow, and the shoulder joint. There are the multiple risk factors, including the low cervical spinal cord injury, high thoracic spinal cord injury, severe spasticity, impaired cognitive function, tracheostomy, pneumonia, urinary tract infection, vascular stasis, and the prolonged immobilization. So the first animal model of the SCI-associated HO was reported in 2015. So in this, in this study, they first performed the spinal cord transection at the T10, T11, and then they inject the cardiotoxin to induce muscle injury on the right leg. And only the mice have combined SCI plus cardiotoxin injection developed the HO. The mice have spinal cord injury alone or cardiotoxin injection alone did not develop the HO. And the HO abnormal mineralization of the muscle can be seen as early as 3 days, and the mineral keep growing until 2 weeks. The histology study shows that there is a abnormal mineralization in the muscle, and the bone structure can be appreciated in the muscle with the lacunae for the osteocyte and also bone marrow-like structures. A very interesting result is that if they inject the cardiotoxin in the front limbs, and the HO forms in the front limbs, not in the hind limbs. So that indicates there are some systemic osteogenic factors plays a role in the HO formation. And they collect the serum from the mice with the different treatment, like from the sham operation, SCI alone, SCI plus cardiotoxin injection, and they culture the interstitial cells from the muscle with the serum added in the culture system. And so the highest level of the mineralization was seen in the culture with the treatment of serum from the SCI plus cardiotoxin mice. So why is that? It's a very interesting result. So this is a qPCR result of the muscle. So after the cardiotoxin injection, there is several pro-inflammatory factors was upregulated, including CSF1, TNF, CCL2, interleukin-1 beta, and oncostatin M. No matter the animal is spinal cord injury or not. And only the interleukin-1 beta and the oncostatin M showed a significant higher level in the SCI plus cardiotoxin injection in comparison to the cardiotoxin injection alone. And they do the qPCR for the interleukin-1 alpha and the interleukin-1 beta. As we know, interleukin-1 has two different types. And at the post-injection 2 days, interleukin-1 beta was significantly upregulated and become decreased at the day 4. On the contrary, interleukin-1 alpha was not very high at the day 2, but it was upregulated from day 2 to day 4. Then they treat the SCI-associated HO mice with monoclonal antibodies that neutralize both interleukin-1 alpha and 1 beta. And the mice showed a trend of decreased HO formation with the anti-interleukin-1 monoclonal treatment, monoclonal antibody treatment. However, it has not reached a significant difference. Both interleukin-1 alpha and 1 beta combine on the interleukin-1 receptor, and so they generate a knockout mice that was defective for the interleukin-1 receptor 1. And after they knock out the mice, there's a significantly less HO formation in the knockout mice compared to the wild type. So similarly, they generate knockout mice that is deficient for the oncostatin M receptor, and that result in significantly less HO formation in the muscle compared to the wild type. But the problem is that the cardiotoxin is a snake venom, and it does not represent the typical clinical injury mechanism. For the SCI, most of the SCI happens after the traumatic event. As shown in the chart, the most common ones are motor vehicle accident and the fall, and also sports-related injuries. So my hypothesis is that once injured, the traumatic spinal cord injury, they may sustain some other musculoskeletal injury as well. Based on my hypothesis, I developed a new mice model of a polytrauma with SCI. So that is how I did it. So first of all, I induced spinal cord injury by doing a spinal cord transection at the T9, T10. And then I induced muscular tendon injury, MTI, by doing the quadriceps crush at the muscle tendon junction with a surgical clamp for 15 seconds, followed by the 2 millimeter tenotomy of the quadriceps tendon. And the mice were euthanized at 1 week and 4 weeks. So the micro CT scanning showed that abnormal mineralization and bone formation only happens in the SCI plus MTI. At 1 week, there's just a faint mineralization of the quadriceps, but at four weeks, the mineralization was getting dense with a high volume. The histology staining here is the von Cossa staining. Von Cossa staining shows the mineralization as a black. And if you see the MTI alone, so there is still the gap from the tenotomy. It was not healed. The tenotomy starts to heal at 4 weeks in the MTI alone group. In the SCI plus MTI, the mineralization deposit, the mineral deposit in the quadriceps undergoes the atrophic change at the same time. And when we zoom in, take a look at the higher magnification images, we notice that the mineral structure at these 2 time points are actually different. At 1 week, this is just amorphous mineral deposit with some fibroproliferative response in between the mineral. And only at 4 weeks, we can appreciate the bony structure. And you can see the cuboid osteoblast lining on the trabecular bone structure. And what's more, there is ectopic bone marrow formation in the muscle. And to further evaluate the cellular activity of the ectopic bone, and we did the von Cossa, we did the LP staining that is stained the osteoblast as a blue, and the trap staining that is stained also classed as a red. So at 1 week, there is a barely positive osteoblast. However, the trap positive cells is very strong. So that indicates that 1 week, not much osteoblastic activity, but the osteoclast or pre-osteoclast is a very active among the mineralization. At a 4 week, ALP staining is getting a lot stronger. That lining around the trabecular bony structure, and the osteoclast co-localized with the osteoblast. This can also shown by the histomorphometry. There is a significant increase of the osteoblast activity from 1 week to 4 weeks, but osteoclast activity is stable. So in conclusion, the pathogenesis of HO remains largely unknown. The prophylactic treatment include NSAIDs, radiotherapy, physical therapy. The surgical treatment is indicated for the symptomatic HO that has already matured. FDA approved the palovarotene for the FOP, and the female patient should older than 8 years old, and the male patient should older than 10 years old. The potential specific therapeutic targets include BMP, mTOR, HIF-1 alpha, interleukin-1, oncostatin signaling pathways. So this is my acknowledgement, and thank you very much.
Thank you very much, Dr. Gao. I'm going to ask people to please enter their questions in the chat, which I will open up in a second to see. Before I open that, are there any questions in the room for Dr. Gao? Thank you. That was really an informative lecture on a topic that we don't hear much about. So thank you so much, and congratulations on the work you've done.
Oh, thank you.
Really interesting. Yes, Joyce.
So I just would want to get my mind around this a little bit. So there's a fibro-osteodysplasia.
Joyce?
Sorry.
We'll get Joyce to come to the microphone.
So just to make sure I understood correctly, there's the FOP, which is a genetic thing.
Yeah.
And then there is the probably trauma-related ossification,
Correct.
which is a separate thing, right?
Yes.
So can you give me some idea of kind of the epidemiology, like how frequent is this? Who gets it more than other people? And how should we identify it in patients? And where should we refer to them to if we identify it?
Okay. And so first of all, so the HO is a very good question. The HO has two big categories, congenital HO and acquired HO. Congenital HO, FOP is the most common one. I can tell you not many patients you are going to see. So after I attend a conference in the US, and this conference discussed about HO, interesting, there's such kind of conference exists in the world. And I was told by the people in Canada, the population of FOP congenital HO is not more than 20 to 30 in the whole country. There's not a lot.
It's very rare.
Very rare. FOP is very rare. And for the acquired HO, that really depends on what is the population you focus on. And generally speaking, HO that happens for the traumatic case, that depends on what kind of traumatic case we are talking about. If that is an elbow injury, that is a hip replacement, if that is some blast injury, the HO volume, the incidence of HO is high. So in other words, it is commonly seen in the patient in the military personnel. But in the normal civilian, it's not that high. And also, I'm also think about there's a lot of undiagnosed HO, because a big percentage of the patient with HO is clinical silent. They do not exhibit any symptoms. And but for some high risk patient, like if the patient have the complete spinal cord injury, and if the patient develops the redness and the pain in some location that you cannot identify the cause, and the HO should be in the differential diagnosis. But the incidence is not very high.
Come to the microphone. Yeah, perfect. Thank you.
John, that was a very nice presentation. I have a question regarding the histomorphometry you show, where you see that the osteoblasts go up and the osteoclasts go down.
Yeah.
So it seems to have an uncoupling type of model or effect.
Yeah.
Because as it should be, both should be going up.
Yeah.
In some level. So is there, or do you know the mechanism? Is there like some kind of inhibitory effect impact on osteoclasts? Is RANK ligand involved? What would be the mechanism there to explain that uncoupling?
Yeah. So it's a very good question. It's a very good question here. Because, first of all, histomorphometry is a very subjective method to analyze. The way that in our lab to do the histomorphometry is that we first go through the micro CT images. We identify the most bone formation site, and we cut the sections according to where we see on the micro CT images. So the place that we choose to do the histomorphometry is the place where the most bone formation. I think that is probably one of the cause you see more osteoblasts at 4 weeks. Scientific wise, I think it's because on the, first of all, trap staining is not very specific for the osteoclast. It can also stain some monocytes. And that is already known from the literature. The monocytes start the cascade of HO formation. So at the site of the HO at 1 week, you see the positive cells that may not be actually osteoclast. It might be some monocyte and the pre-osteoclast. That is what I'm thinking. So that's the reason why at the current stage, I'm going to do more immunohistostaining to identify what are these positive cells.
There's a question in the chat, maybe you can just read it to there.
Yeah, I think that the question is that is the pyruvaritin available in Canada, any trials on it for the treatment of a traumatic HO? And I'm not aware of any trial of pyruvaritin for the traumatic HO, but the pyruvaritin is available in Canada. It was manufactured by Ipsen, and I was approached by someone that probably I can prescribe. But actually, in my outpatient clinical practice, I barely see the patient with HO.
Dr. Roger.
Thanks, Dr. Gao. Great, very clear presentation. I wonder if you could, I mean, it sort of sounds from your description of the condition that really the focus needs to be on prevention. And I wonder if you could sort of talk about sort of any risk stratification tools for the acquired HO that have been developed. You know, some of these therapies or preventative therapies that you've mentioned, like radiotherapy, sound sort of not very realistic for every total hip replacement. But is there specific subpopulations where you'd want to target the preventative interventions?
Yeah. Okay. Sure. So the question is that there are any tools that we can stratify the risk of the HO development. So for the preventative hip radiation before the hip replacement, some literature suggests that actually the clinical practice always guide the radiations indicated for the high risk patient. But what is a high risk patient? There are 4 points. So what I can remember is that first of all, the patient have a history of HO. Second of all, the patient have a hypertrophic osteoarthritis. So that means that there's a lot of osteophyte in the osteoarthritis. And also there's another one is that the patient have the diffuse idiopathic skeletal hyperorthosis. So if you take the X-ray, you will see the ligament on the vertebrae is all ossified. And I forget what is the other one because I do not see this patient very often in my clinical practice. And I don't know there's like any like a scoring system to see that the high risk, the moderate risk, and the low risk. I'm not aware of that.
Go ahead,
I'm Wallace. I work in nuclear medicine, and we used to assess the bone maturity with bone scanning, and if we need it, we do also with bone marrow scanning. We have a protocol for that, and they needed to test two times 3 months apart to see the degree of maturity. Do you have any comment about new things that I did not review the recent literature?
So you are talking about the triple phase bone scan?
Yeah, we do a baseline, and we measure the degree of activity.
Okay.
We also measure the flow.
Okay.
And we repeat approximately 3 months after.
Yeah.
If the activity is higher than 3 months before, it's not yet mature.
Okay.
When the activity is equal or less than 3 months before, the heterotopic bone formation is mature, the surgeon can go ahead. If we have a doubt, we can still do bone marrow activity scanning, and if the bone marrow is present in the heterotopic bone formation, implies that it is mature. I noticed that biopsy is very good to assess maturity, but at the same time, biopsy is only in a small amount of the entire lesion, so may not represent the entire process. And I don't know if making a decision on the basis of the biopsy, it may be not optimal because other sites of the lesion may not be mature.
Yeah,
I don't know if you have any comment.
I don't have any comment.
Or the new things that I did not review the literature recently.
Yeah, I don't have any comment, but I appreciate your comment. Your comment actually bridged the knowledge gap in my brain. I don't know that you can do the bone marrow scanning and to evaluate the maturity of the HO. But in our textbook for the physiatry, yes, the triple phase bone scan is to diagnose the HO and also to evaluate the maturity of the HO. And the delayed phase is most important.
You need to repeat.
I need to repeat. Yeah.
Otherwise, you
Yeah.
cannot make a conclusion.
Yes, very good point. Something learned today. Great.
I don't see any more questions in the chat, but just the last question coming back to what Dr. Pickering said. So if we think, so if I understand correctly, if we have people who've had an injury and have persistent pain or redness, or I guess a fullness at the site of the injury, we would consider HO as a possibility, as a potential diagnosis. And what would we do with such a patient? Where would we refer them?
So first of all, when you see the patient after traumatic injury, they have a redness, they have a swelling, there's several differential diagnoses in the mind. We should consider infection, we should consider DVT, right? That's thrombosis, and we should consider HO, and also we should consider compartment syndrome. We should consider all of that. And if there's any doubt, I think the triple phase bone scan is a good thing to do. And also you can start the treatment, the therapeutic trial with the insights.
And then where would we refer them?
Refer them, and to be honest with you, although my research is in the HO, but I do not see the HO patient very often.
Does anyone?
Does anyone? Let me discuss with someone else and
Okay.
get back to you about that.
Fantastic. Thank you so much. So first of all, again, congratulations. Thank you for opening
you.
up our grand rounds for the year. Wonderful lecture, and congratulations on the work that you're doing, all the research you're doing in this field. So I'd like to thank everyone for joining us today for our medical grand rounds, and see you next week. Once again, this is hybrid, and if you're at the Glen, please do drop by D01312 to join us in person, and a chance to mingle and see everyone and have a light lunch with us. So thanks everyone for being there. I wish everyone a great afternoon. Thanks again, Dr. Gao. Thank you.